right, we're going to go ahead and get started. It's my pleasure to introduce Dr. Sudak today, and she's going to be talking to us about loneliness. Dr. Sudak is a professor, vice chair of education, senior associate training director, and director of psychotherapy training at the Department of Psychiatry at Drexel University. She's a clinician educator with a wealth of experience in teaching and patient care. She's made a number of contributions to the research in CBT and has played a major role in developing suggested curriculum and guidelines for resident competency in CBT. She also has multiple publications regarding combining treatment with medication for CBT. Her recent book, Teaching and Supervising Cognitive Behavioral Therapy, written with a group of noted experts in CBT education, provides multiple resources for educators. In addition to her teaching responsibilities at Drexel, she's an adjunct faculty member at the Beck Institute. She is a past president of the Academy of Cognitive Therapy, the former editor of the PSY examination, has served on the board of regents of the American College of Psychiatrists, and serves on multiple national committees and the Association of Behavioral and Cognitive Therapies and the American Association of Directors of Psychiatric Residency Training. She is the immediate past president of ADCORD. Please welcome Dr. Sudak. Everybody hear me okay? Great.
So this is a topic that I started to be interested in because someone was doing a presentation at the APA and said, would you do something to talk about loneliness? And this was probably 5 years ago, and I kind of scratched my head as I was asked to do this, thinking to myself that I had never investigated this. And that seemed odd to me. It seemed odd to me how little we talked about or thought about that in regards to our patients, almost seeing it as a part of an illness rather than as an entity itself. It reminded me a little about like the way we used to think about insomnia. We used to think about insomnia as something that, well, you treat the depression and it would go away, or like suicidality, where you treat the depression and the suicide will go away, when in fact it might be something independent to think about and treat. And that's why I got interested in this. And there's disclosures, I write books, and none of them will be referred to in an off-label way in this talk. The analogy I think is really worth thinking about is alone is to lonely as awake is to insomnia. Right? That alone is to lonely as awake is to insomnia. That many people, when they're awake, don't feel a lot of distress about it in the middle of the night, don't have a lot of rumination about it, don't develop all kinds of behaviors around it that make it worse. And it's true that many people who are alone don't develop the same constellation of symptoms that happen when they have loneliness. So here's what we're planning to do today. We're going to look at loneliness as a biobehavioral stressor that causes lots of inflammatory processes and problems with your health, not just problems with your mental health. We'll figure out who's at risk for this, and then maybe look at some particular ways of tackling it that naturally sort of gravitate for me from the area of CBT. So let's think about it for a minute. It's not about being alone. Loneliness is an unpleasant reaction. It has cognitive and emotional components that really has to do to the discrepancy between the relationships you want and the relationships you have. Right? It's not the same as being alone. And it has this sense of deprivation and distress about it. So it's a sense of being left out, a sense of being unloved, a sense of being more than just lack of companionship. And then some of what I think is really important relative to CBT is that it is a perception, and often a misperception about social connectedness. And so that's one of the reasons it sort of resonates with me as something to fix. The other thing that's kind of interesting about this, and a lot has been written about this in the media, is the relationship between social media and loneliness. You know, that there's a lot of stuff about, oh, we have 1 million friends, but we're still really lonely because we don't interact with one another, and that we've lost the ability to be really truly connected to people because of social media. And I think that that might have some importance about it, It is true that with college students, the more time they spend on social media, the more likely it is that they'll be depressed. And the more time they spend in direct socially relating to someone in actual face-to-face interactions, the less likely it will be that they're depressed. In that association, nobody's saying causality, but it seems to have something that's connected there. I think the issue of social media is much more the issue of comparison. So here is a person who's prone to being lonely on social media, who has misperceptions about their desire in actual social relationships. And they look at the web pages of other people, Facebook pages of other people. Well, generally people don't post pictures on Facebook sitting alone on Saturday night with a pint of Ben and Jerry's. You know, they're posting pictures of, you know, being with other people, having fun, doing all these things. And so people make comparisons about their own life with the pictures that they see on Facebook, and that furthers their misperceptions. So the first question you might ask yourself is, why do we have this? Why do we feel lonely? What is it that gave us this wiring? Because we know that this is something that's hardwired, that potentially people are wired to make connections. And when we have disruptions in those connections, we have this unpleasant sensation that essentially says, hey, wait a minute, you need more of those. There's something that you aren't doing to get yourself involved with other people. And people have that in various amounts based on probably their genetic predisposition to this. And the connectedness probably comes because we need social groups generally to be able to survive, or at least we did back in, you know, in the cave days. We really needed social groups to survive, and to potentially rear our kids until they were old enough to survive on their own. Now, there's sort of this trade-off involved, right? Because if you were able to survive alone, all of those resources could be yours. You know, if you killed a boar or something, it would all be yours to eat as opposed to sharing it with everybody else. So there's some people who think that for some individuals, the idea of being solo might have evolved as a genetic preference because of that. But most people believe that there's some heritable tendency to want to have other people connected to you, to value, to trust, to communicate with, to plan and have a future with. So that we think about loneliness as a signal to get us to wake up and say, oh, I need to do something about my connections. So that loneliness really probably has something to do with isolation plus behavior. So social isolation is not the same as loneliness, although it still conveys some risk for people. Right? We know that social isolation both increases risky health behaviors. The less well-connected you are to other people, the more likely you're going to eat too much, drink too much, smoke cigarettes, etc. We know that social isolation actually makes it harder for people to recover from illness. And so we need to sort of separate out the idea of social inclusion, loneliness, as things that are both independent things to consider when we consider rehabilitating patients. And some people all have, from the beginning, have trouble forming connections. But there are often life circumstances where we lose our connections, and that's a time often when loneliness really comes to the fore. And many people who do okay will respond to that feeling, figure it out, find social connections, and then feel better. A great prototype for this is college. Kids go from a high school where they have lots of friends and lots of people around them that are supporting them, and they go to college, they go somewhere far away, and they don't really know anybody, or maybe they know one or two people, and in the very beginning, many of those kids feel very alone, isolated, and lonely, and the majority of them will sort of do something about it. They'll pay attention to that signal, and they'll find some ways around it. But some individuals compound that sensation of being lonely with sets of cognitions and behaviors that set up this cycle to make things worse. So they have a consistent perception that their social connectedness is not what like everybody else's, and they often do things in relationships because of that makes things worse for them. So how common is this? It's really common. And if I were to, before I show this slide, I should have done this, I didn't, ask you what group you thought was the loneliest, most people say that it's old people. But in fact, it's not. The loneliest group, most people who complain the most of loneliness are young adults, interestingly enough. Although the people who are most consistently lonely are often older people. So young adults at a snapshot will say, I am lonely, I'm not satisfied with my relationships. It's also true that it's really common. If you look at this, like 33% of respondents in the UK are saying they are often or very often lonely, and stigmatized groups have a bigger problem with loneliness. People who live alone, oddly enough, are just a little more likely to feel lonely. That's not really the issue, but they feel shame about being lonely, and it's interesting, they have higher empathy scores. They seem to tune into the feelings of other people more, and they have lower levels of trust or expectations. Now, the UK now has a minister of loneliness, which sounded like something out of Monty Python to me, but really, it's because of the sense of so many health risks that go along with it. The other thing about being older is that older people in general have less intense emotions. The gift of age is that you have a better prefrontal cortex. And they also have coped better with adversity, and they may have expectations. You know, a person who's 80 years old, whose friends start to die off, sort of often will see that as being the logical trajectory. You know, they might replace those relationships, but they might not feel like it's as much of a catastrophe as a 20-year-old or 25-year-old who really feels bereft of relationships. This is us in the US. We're looking at 50% of people almost who feel sometimes or always left out. 20% never feel close to or have people to talk to. Again, 18 to 22-year-olds feeling the loneliness. Unemployment being a factor. This has really been remarkably consistent over surveys over the years. And another big finding that about 30% of people over 55, 20% over 65, endorsing that for much of the week, not just now and again. Other risk factors is to be female. Women are more often bereaved and widowed. They often live longer. They're more likely to be depressed when we're never sure with depression which comes first, right? The loneliness or the depression, so that's an issue. Single parents, people who are spending a lot of time doing something that keeps them from tending to their own relationships. And those folks that, at least when I was a kid, we used to call shut-ins. People who are really unable to leave their homes because of illness, have a really hard time socializing, have a higher risk of this problem. And here are the things that protect people from loneliness. And one thing that I think is really useful to think about, because as you treat loneliness, you want to really help someone. And is this going away? It is, so I'm going to use the podium. I think it's the battery is going, so we're not worried about it. So as you treat people for loneliness, you want to think about this, is that regular traditions with other people seem to be protected for loneliness. So like Sunday dinner, right? So I don't have a very large family of relations, but I have a pretty large family of intention, and I do Sunday dinners. So my people come over and we all sort of hang and have dinner together, and different groups at different times. It's a really nice thing to do, and sometimes it's not very scintillating, and sometimes it's a whole lot of fun, but we do it routinely, and that seems to be one of the protective things about loneliness. And you can see that just being involved with groups makes a difference. So those are things to keep thinking about as you try to treat loneliness. The big thing about this is that loneliness is just plain dangerous. It increases your mortality as much as smoking 15 cigarettes a day, right? Surprise. And it really increases your risk for cardiovascular illness. In fact, really what happens when you have loneliness is that your HPA axis is awoke all the time. You're just pouring out stress hormones. And so it has a lot to do with increased mortality. Social isolation does as well, and the combination is the worst. So if you have social isolation and you are lonely, that is the biggest of the problems. It's nearly equal to the risk of being poor. So being poor, you have a 20% increased risk of premature death. Being lonely, you have a 14% increased risk of premature death. So add those two things together and things get a lot worse. It increases all kinds of bad things from mental and physical health outcomes, and that's controlled for tons of stuff. For age, gender, socioeconomic status, isolation, poor health behaviors. So there are mental and physical health consequences of this. Actually, if you're lonely as a kid, you have a higher rate of cardiovascular disease as an adult. So even into childhood, this can happen. The other thing that happens is that your brain starts to function worse. And we're not really sure which comes first, but it is true that social isolation and emotional isolation, at least the perception of that, i.e. loneliness, is associated with cognitive decline. It worsens the prognosis in dementia. If you have two people who have dementia and have identical psych testing results, and then you look at their activities of daily living, if one of them is lonely, the person who is lonely will function at a level that is far worse than the person who is not, even if their psych testing results are the same. So we think maybe what happens is that loneliness increases the clinical expression of dementia. Right? So there's several studies that have shown this even with autopsy findings. So if you look at autopsy findings of individuals who are functioning really poorly, and individuals who were lonely, and individuals who were not lonely and functioning reasonably okay, their brains may look the same on autopsy. So John Cacioppo was really the giant of loneliness research, and he actually just died prematurely of cancer. And he really looked at loneliness as being a neural signal that says, hey, we got to do something to preserve ourselves, kind of like anxiety, right? So if we think about the model for anxiety in CBT, what we think happens in anxiety is that everybody has the predisposition to get anxious. It's a normal signal. But that the person who develops an anxiety problem, when they get anxious, develop a whole cascade of thoughts and behaviors that perpetuate a sense of being under chronic threat, even though it's not dangerous. Right? So the person who has an anxiety disorder might be scanning the environment for danger, might be looking for evidence if they are anxious about potentially social things. They might be looking for evidence for negative evaluation by other people. They might avoid certain things that they perceive are dangerous, like avoid social interactions if they have social anxiety. And that's going to be a person who has a greater sense of fear as a result of all the things they're doing because of that initial anxiety. And what Cacioppo postulated is that the same thing happens in a lonely person. That a lonely person begins to develop ideas about themselves socially, behaviors, beliefs, heightened sense of threat, social threat, that make it more likely that they stay lonely, that they isolate themselves, that they do things in interpersonal relationships that are problems. So for example, a highly lonely person might go to a party and notice all the people who don't talk to them instead of noticing the people that do. Or might be really hostile to the person who comes over and says, are you enjoying yourself? And they might say, no, I don't have anything in common with anybody here. Which would give them social information about themselves that would confirm things and keep the cycle going. And actually, if we look at some fMRI kinds of things, what we find out is that lonely people have biased attention to negative social stimuli, right? So that they are more tuned up for threats about things like that. And we also know that lack of social contact is really stigmatized in the world. right? How many of you feel really great about going to a fancy restaurant by yourself to dinner? Right? Oh, I can't wait. You know, I don't know about you, but if I'm at a convention and I'm by myself, it is room service. I'm going to work, I'm going to watch Game of Thrones, I'm going to have my dinner. I'm not going to be by myself in that restaurant. It would be terrible. I know people who also, how many like to go themselves to the movies? Right? Right? So lack of social contact is really stigmatized. And I wouldn't sit there by myself, people would look at me. And it leads to further damage to someone's self-regard. Even though, if you measure social skills in lonely people, many of them are not less than average. And so they start to have cognitions. I'm a loser, I'm unfortunate, sometimes have behaviors like smoking or eating or drinking to relieve whatever pain that they have, and they might avoid social interactions. We also know that folks with severe and persistent mental illness have incredible impairments in their social networks. Reading this about patients with psychosis is just amazing. This is a study. 80% of people who have psychosis experience loneliness. 48% say they need more friends. Almost 70 say they haven't attended a social activity in the last year. And 43% say that stigma is a barrier. If you look at it, their opportunities are fewer, they're not working, they have less money, they have skill deficits. They get smaller and smaller in the way of their social network over the course of the illness. And people who have psychotic illnesses also need maybe more than a network. So if you look at studies, they need to learn how to be reciprocal. They need to ask other people questions about themselves and have reciprocal interactions. They also might need to sort of check out dysfunctional appraisals. Confidants help with that. And then they need help with sort of threat-based perceptions about social interactions. Anybody here know what befriending is in this room? You do, because you've been in my class. You remember. Befriending is this great sham therapy that we use. It's not really a sham in some ways, but it's used as a control condition in a lot of psychotherapy studies, particularly with patients with a lot of psychotic illnesses. And what it is really just being somebody's buddy, not taking them to the cafeteria, talking about what they're interested in, being interested in life experiences that they're having, talking about movies or affiliates or whatever. And if you actually study patients who have schizophrenia, and you provide them with CBT and befriending, while they have befriending, they actually have the same diminution in psychotic symptoms as if they have therapy. But when the friend goes away after the control condition is removed and the therapeutic condition is removed, CBT folks get continually better, and the person who has no friends starts to get symptomatic again. So that having relationships may really be beneficial. Depression is a little different. We know that we're not sure which comes first, right? So the people who have depression often complain of loneliness. People who are lonely often complain of depression, but sometimes it's a chicken and egg phenomenon. We do know that hopelessness exists in a higher rate in depression, in social isolation, and in loneliness. Hopelessness exists in all three. And if you have the combination of 2 or 3 of those things, your level of hopelessness is really very high. And we need to also remember that hopelessness is a bigger correlate of what class? Anybody who's had classification of this? Of what? Of suicide, right? So that all of these things will increase the risk of suicide. So here are some resources for patients. And I want to give you this sort of in the middle of the talk, because in fact, if there's nothing you're going to remember about this, this is what to remember. The very last link is a free book called the Social Enhancement Workbook that you can download for free for patients. It is written for chronically mentally ill folks. It's how to both assess your relationships, build your relationships, how to form networks, where to meet people, how to use social media safely. It is an absolutely fabulous resource for And if I'm going to use it with patients who don't have a chronic illness, I explain that it's been written for a wide range of people, but it is fabulous. And it has people look through, do an inventory, and make an action plan of the things they're deficient in order to have more people in their life. It is really terrific. So that's that very last link. NAMI is great for folks in terms of increasing networks of support. Anybody know what NoLongerLonely.com is? It's Match.com for people with chronic mental illness. It's free. It's a dating service. There's lots of sort of protective things around it. Good thing to know about. Strengthofus.org. Anybody know what that is? It is a Facebook for teenagers who have severe illnesses, psychiatric illnesses. That is actually now subsumed in the NAMI page. You can't get onto it without having joined that. So there's a little more protection about it now. Anybody know what ICCD is? Who knows what clubhouses are? Nobody. Okay, so we have several of them in Philadelphia. This is the International Clubhouse Association. Clubhouses are actually a nonprofit association that are formed for individuals who have SPMI. And they are actually gathering places. They have libraries, they have gardens, they have a kitchen, they have resources for work. Every person who has a mental illness is eligible to go to a clubhouse. They have groups, and they have a leadership and a board, etc. If you join the clubhouse, you get a job. So if you're given a job as a part of the clubhouse, you either work in the library or you participate in the garden. And they're an incredible place for people to be able to have interaction socially and get some resources and benefits that they're entitled to. I believe there's one in the Kensington area, there's one in the Northeast. I think there are 2 or 3 in the Philadelphia area. So there are communities of folks who really seek to try to make situations better for folks with severe illness. And this is the UK's campaign, which we're going to see something from in a few minutes. So any questions about that before we talk about treatment approaches? Just a few things that might be helpful to you as you work with patients. So I think about loneliness as something that really sort of lends itself to my approach to treatment. And so part of what I want to do is I want to assess things about it independent of the psychiatric illness, just like I would insomnia or suicide. I want to think about, is it social isolation or is it loneliness, because I might approach it differently. I want to conceptualize it, right? I want to know, what is it that keeps this going for this person? How do I understand that this developed in this person? And how is it that I can think about making it better? Because every person who's lonely has different triggers, has different cognitions that set it off, has different sets of behaviors that keep the problem going. And so I'm going to be looking at conceptualizing it in this particular person and then coming up with ways to remedy it. You can start out by giving somebody the social enhancement workbook and saying, this is a good self-help tool. And if it's somebody who's going to take it and run, they may just use that and start working on things on their own. I have often had residents actually use it as a manual with patients. I've used it, sections of it as a manual, where the patient and I will go through it together. Right? It's a really nifty way of doing that in a modular sort of way to help the person. But if that doesn't work, there are evidence-supported ways of managing loneliness. And the last has the most potent evidence. So if somebody needs improvement in social skills, you need to give them skills, right? No amount of talking about cognitions will ever replace a skill that you don't have. You need to help the person notice quality relationships, not quantity, right? You need to maybe adjust cognitions about expectations. If you ask lonely people how many friends people have, they will often grossly overestimate how many friends people have. And they often also grossly overestimate when they first meet someone, the amount of social connectedness they feel for friendship, right? I met this person at a party, and we really seemed to get along really well. I know for sure they're going to be my friend. Well, generally speaking, you don't, right? You might sort of have that initial, I mean, it's sort of like love at first sight about friends. And you have to help the person with cognitions around that. That is this part. You want to increase their opportunities to get connected to other people. That's mostly behavioral. But the cognition-based interventions have the biggest punch. And these are all the things that I would do. That's a prototype for an approach that CBT would take to almost anything. And so we're going to do that just for a little bit, looking at how we might do it with a lonely person. So how many of you ever ask patients, do you feel lonely? Yay, yay for you. It's a good question to think about asking folks, right? Because we don't do that often. And that's different from asking who's in your life. It's different from asking qualities and how many relationships somebody has. It's asking about quality. It's asking about how they assess that. There is a loneliness scale that you can get. Just Google UCLA loneliness scale. It's got 20 items rated on a scale of 1 to 4, and never to often, kind of Likert scale. And I like thinking about it in domains, because I think you can protect yourself from being lonely by having domains of social interaction, having an intimate partner, having family and friends, having a bigger collective domain, being a part of something bigger, like a yoga class, or a school, or a church, or a gym, or, you know, I happen to go to the gym at the same time every single morning. Yes, it is 5:30. And I see the same people at the gym at 5:30 a.m. And actually, when I have moved from city to city, I've always pretty much found somebody who got to be my friend that I saw at the gym every day at 5:30 in the morning and got to talking to and eventually got to be close to. So having a collective group can also be helpful. And joining a collective group when one has a particular interest in something is sort of a natural segue in terms of getting to meet people that might become friends. Helping people to normalize the notion of loneliness. Everybody has this signal. It's there to be protective of you. And so you've got to use that signal to think about developing and repairing relationships. And maybe looking at how this signal over time has affected you in terms of your beliefs and behavior around relationships. Because generally, you're not going to see the person who's lonely for 10 minutes. You're going to see the person who's been lonely for 10 years. And they're going to look very different because of the strategies and ideas that they've gotten because of that. So this might be a conceptualization. It's Saturday night. The person's by themselves, sitting watching television with that Ben and Jerry's, saying, I am lonely. They might say, nobody else is lonely, just me, and start to ruminate something is wrong with me. So since something's wrong with me, I'm just not going to go out and try to meet more people. I'll get more defensive. I'll look for signs of rejection. If somebody, I meet someone, we go out and have coffee, and then they don't seem to call me back, I don't call them because I think it's not fair that I always have to be the one that's doing the calling, or I get upset that they haven't called me, so that by the time they call me, I'm kind of snippy with them. And so that would produce the very outcome that I might be afraid of, make me less approachable. So this is a person who attends much more preferentially to negative social information, and we would have to figure out how to break that cycle in therapy. Sometimes it's easy. That other part is harder. Sometimes it's easy. It's just figuring out where should this person go for more interactions. How are they going to meet more people? They need to be able to, number one, brainstorm ideas about where they could go, you know, like volunteering, going to church, and figuring out how to take that to the next level. How to ask the person who you're volunteering with to go out for coffee, right? How to approach somebody in that particular way. And so this is usually item one if the person isn't doing it. And then what happens when you prescribe something behaviorally is that the roadblocks that come up are often the cognitions, are often the cognitive strategies that you have to work with and modify so that the person does the things that normally you would do to repair things, right? So one of the things you can do is to just take a behavioral approach, problem solve things, decrease coping mechanisms that are harmful, maybe just use activity scheduling. All of you who worked with me have seen this. This is a way of planning activities. So you have, you schedule it during a particular time. So it might be, go online to look up what meetups are going on, actually schedule myself to go to a meetup that I'm interested in. And you might use a behavioral activity homework sheet to assign a particular activity to the person. It makes it more likely that people will do something that they're not doing, to have a written stimulus that has a really clear plan about who they're going to do something with, where they're going to go, what they're going to be doing, and in advance, what are the obstacles going to be, so that they're actually really problem solving the roadblocks that they usually set up for themselves. Now, sometimes those obstacles will be cognitions, in which case we're going to do something else. We'll get to that in a minute. Sometimes we need to do skills training, right? It's very frequent that people who wind up in my office don't have very good ideas about social causality. Anybody know what social causality is? They don't have a good sense of the effect they have on other people, right? They don't have a good sense of what it's like when they walk into a room and don't make eye contact, right? Or when somebody asks them a question and they give them a one-word answer, right? They just don't have a good sense of that. And so role play is often a really helpful thing to do about that. Sometimes role play will get to the cognitions that are uncomfortable. When I feel really anxious when I make eye contact for too long, and helping the person to learn to do that a little more. We might really help them with being more reciprocal. Sometimes, depending on the person, we have to teach appropriate amounts of sharing, not oversharing, not undersharing, right? And so sometimes that's called social causality too. We might have to model how to express opinions, how to share sadness. This often is the case in folks who have severe illnesses, right? And so one of the things that happens is that there's too much at once and they overwhelm people that they're with, right? Not everybody has your training. So that can be a very big help to people. And then we want to look at the cognitions and behaviors that are going to be problems in the road. And so we want to look at what is it that you can change to get things to work better, and manage inaccurate cognitions. So one of the things that we have to really watch out for is discouragement when things take time, right? It's discouragement when things take time. Many of you will have had experience with this, right? Having to manage discouragement when not having relationships the way you go, the way you want to, takes time. If you've dated, you have managed that discouragement, right? And most people really struggle with that, but find ways to sort of get around the idea that it's very hard to constantly put yourself out there, and sometimes it works. Sometimes it works for a little while, sometimes it just doesn't work. And it's a lot of effort and time, but people keep doing it. And the drive to reproduce is pretty strong, or the drive to have close connections with an intimate partner is really strong. But you have to really manage that over time in order to keep doing this. So I really talk about the fact that having relationships is work. It really takes work. It's worth having, but you have to be able to deal with those kinds of assaults. So one of the things that folks who have this problem often do is attend to negative social information. Those are cognitions you want to correct. No one is talking to me. No one spoke to me at the party. They recall much more negative aspects about social encounters. Person didn't call me back, ever, for 1 day, 2 days, 3 days. And they have lots of negative social expectations. I didn't meet anybody at this party, or I didn't meet anybody at this meetup. I'll never meet anybody again. So you really have to manage those kinds of cognitions. All right, so most people in this room, at least many people in this room, know what this is, right? This is the basic model that we're thinking about when we're thinking about helping people to change. We generally can't change this very easily, but we know that what happens after a particular particular events like going to a meetup is that people have all kinds of cognitive appraisals of those events. And those tend to be of varying degrees of accuracy. And when we have particular events about thinking in certain ways, or when we have depression or anxiety, those appraisals tend to be far skewed and far negative and far more inaccurate, and often lead to or are associated with unpleasant emotion and sometimes behavior that keeps the problem going. And that's essentially the model with which we're going to tackle most of these if we're using CBT, and in specific, we'll be looking a lot at cognitive appraisals that are incorrect. And in lonely folks, I think it's really helpful to think about these with folks as Achilles heels of mind, because they are really chronic for many folks. They have mindsets that get activated in certain circumstances. And when they get set off, if they're not able to step back and say, wait a minute, this is the old way I used to think about this. It gets set off under these circumstances. I need to stop. I need to get a little more perspective. I need to step back and look down from the balcony, which is a nice metaphor for folks, and say, is this really 100% true, or is this the way that I've seen things, right? So that's a really helpful thing to be able to do. It's an Achilles heel, it's something I'm prone to. It might take a long time for those Achilles heels to get better. These are the kinds of cognitive errors that patients who are lonely make. The reason I have fewer friends is that I drive people away. There's nothing I can do to have more people in my life. The only reason people are nice to me is because I do things for them. Everyone else has more friends than I do. It's not fair that I have to be the one who always does the phone calling or the arranging or all of those things. And you can see those are really sort of absolutistic kinds of statements, highly negative, may be factual, may not be factual. We never know in advance if something is true, not true, or partly true. But it really helps to sort of say, let's just take a step back and look at this. And be able to really get some sense of whether or not this is something that's true. We know that folks who are lonely have some things that need correcting, that they tend to be more cynical, more distrustful. They rate themselves in social situations more negatively. They rate other people more negatively too. They have biased negative memories of their interactions. And so all of these are things that can be corrected by using just the kinds of tools we use with any other folks in CBT. There's a nice acronym. This is a Cassiopo acronym called EASE. E stands for extend yourself. A stands for make an action plan. S stands for seek collectives, right? Lots of groups of people. E stands for expect the best, right? So that if you like using acronyms, that's a really interesting or handy rubric for a lonely person. So importantly, for those of you who haven't had my class or haven't had it yet, the most important thing is you're not going to tell people what to think, because telling people what to think doesn't work, right? And really, it wouldn't work for you either, right? A person who really believes something, if you say, no, it's this way, even if they're going to be nice to you about it, they'll say, yeah, that's fine. And then when they leave your office, they'll say, they don't really know what they're talking about. That works for other people, it doesn't work for me. And so it's really applying the scientific method to your thinking. That's what CBT is all about. The scientific method exists because thinking biases affect the way we see data. And so what we do in CBT is teach people that their own thinking biases affect the way they see data. They're the thoughts that they come to believe about themselves, or about other people, or about the future, all those things. And we try to help them to be a little more scientific. Might be true, might not be true. If it's true, we've got to solve the problem. So we do that with all kinds of questions. We do that with Socratic questioning. What's the evidence that my thought's true or not true? Can I explain this in some other way? If I'm anxious, I can ask the problem questions. Worst, best, most likely. What's the effect if I believe this? What if I changed my thinking? What would I tell my best friend or my family member? Probably wouldn't use best friend here because they're lonely people. If they viewed this way, what should I do right now? All of those are helpful to get people to change their thinking. We might use a thought change record. They look like this, but they're really just a structured way of employing the Socratic method about a thought. But the end point is to come up with a new way to think about a situation. And we do that in a lonely person as well. And then we'd want to do things like help them to remember the next time they go to a party. When they have this particular thought, here's what they have to rehearse. So that's a little something about how we do things with loneliness. I have a video to show. I don't usually show videos, but I happen to like this one. And it's a UK video about someone who is working to combat social isolation. And I actually think this is something we ought to think about a little more with patients. So I kind of like to close with this, particularly middle of the day on a Friday.
So today we're doing Bollywood, as you can probably tell. It's not really my forte, the dancing, but you've got to give it a go, right?
Oh wait, yes, it's old age pensioners.
Yeah, with us.
Oh, yeah. It just wasn't ticking all the boxes. And I wanted to find that something extra. I befriended an older neighbour through a charity project. So I visited her every week. And while I was there, I never envisaged starting a charity. I just wanted to give it a go and even just help a couple of people. My mates think I'm nuts. So when I told them I was leaving London to come back to Doncaster to start a charity with all the people, the reactions were priceless. What are you doing? Like, you're going backwards, like, you're nuts. And you know, they might have had a point. Hi, how are you? Want to come in? So once a week, a volunteer will pop in, have a cup of tea, have a chat, and just be there for someone. Loneliness is crippling. It's the monotony, the never-ending cycle of day after day, week after week, not seeing or speaking to another person.
I was married 47 years, so together more or less 50. And then suddenly, he won't stop. Colin was my best friend, and we did everything together. I felt very low, and he put me onto a thing called social prescribing. And then before I knew it, Mike was coming and bringing Susan, and you know, I've never been happy. It was the best thing I did.
Yeah, it's not just PHA. The Bollywood brings so many elements into it that you don't realise. Remembering routines, physical activity, so it's both mentally and physically engaging.
I think people let their hair down last year, which they wouldn't do outside of this room.
It's such a good idea what he's doing to help people like this.
It's fantastic because I don't have any.
Sham therapy for a period, I believe it was a 12-week time period. And they measured rating scales of the severity of their symptoms before the treatment, after the treatment, and then 6 months after the treatment stopped. And so there was really not a significant difference between the response that both the friend group and the CBT group had to the intervention until after the treatment stopped. When the CBT group continued to have gains made, and the folks who had friends then not only didn't taper off, they didn't even maintain what they had, they actually went back to having as many symptoms that they had at the beginning. Any other questions? Well, thanks for having me back.